Good afternoon, everyone.
Yes, please, Dr. Vivek, please start your talk.
Yeah, so after such an interesting session on live surgery, now we are moving on to a malignant topic. So I hope this malignant topic does not intoxicate you. So we are going to talk something very basics of orthopedic oncology, which is about the biopsy. And get it right first time. That's very important because finally, whatever we do totally depends upon the histology and the way the case has been worked up. So though this is a video demonstration, but I will quickly cover the various points that we need to know about biopsy. So we are quickly going to cover the types of biopsy that we do, the principles of biopsy, and a video demonstration of this technique. Broadly, what is biopsy? In biopsy, we take the tissue to identify the histology of that specimen. That's how it is done. Now, many a times, so many people confuse FNAC with the biopsy. So both of these are totally different things. Please remember, in bone and soft tissue tumors, there is no role of FNAC in primary diagnosis. I see almost 80% of the patients who have been worked up outside, they come with a FNAC report. FNAC is only aspiration cytology. You aspirate the fluid. Nowadays, we need to know much more about it, the grade of the tumor. It's not just that we need to know whether it is malignant or not. We need to give chemotherapy based on the type of grade, histology, and further molecular studies. So this does not mean that when we do biopsy, we make a big opening and take adequate tissue. Still, that is also done with the needle, but the amount of tissue is a little more than what we get from the FNAC. So some basic principles, I think everybody is aware, we learned it from the first day in orthopedics, that it should always be performed after complete radiological and clinical workup. Why it is important? Why not do the biopsy just after looking at the X-ray? If it is showing a good lesion, just go and put in the needle. Because the tumors, especially the sarcomas, are heterogeneous. It has high-grade components, necrotic areas. So we need to carefully analyze with the MRI which area you plan to biopsy, and accordingly, it directs your biopsy part. Why the biopsy should be done by the team who is going to perform the final surgery? This is also, we always read this, but what is the importance? You know, when we do a biopsy, the biopsy tract needs to be excised completely because it is seeded with tumor contamination. So we have to take it out completely. That's why your final surgery has to include this biopsy tract. So unless you are going to operate, you don't know where the final scar is going to be, you may end up doing biopsy from the wrong site and it may contaminate things. Avoid opening the planes. We are taught to go in internervous plane. That is not how biopsy should be done. You need to go directly through the muscular part so that the hematoma or the tumor tissue should not contaminate. The blood should not go into the internervous plane and seep down. So if you see a picture like this, so we need to, you see this is heterogeneous. So some part is cystic, some part is solid. We need to target the solid region so that you choose the right area. And usually in such locations where the vessels are closed, nerves are closed, you can use image guided with USG guided or CT guided biopsy. If a tumor has both bone and soft tissues, whether we need to biopsy both from soft tissue or bone or only soft tissue will do. So remember, we can do only from the soft tissue provided it is the representative sample. Unnecessarily poking into the bone may lead to risk of fracture. If we are doing an open biopsy, a meticulous hemostasis is very important. Every drop of contamination from the tumor part leads to seedling of the tumor cells in the vicinity. So a meticulous hemostasis is very important. So this is what I was showing, that doing the right biopsy is very important because we need to excise that part when we do the final surgery. Now, as far as possible, avoid drains. Like this case, you see, this is a long biopsy, and you see two drains totally in the separate zones. So when we have to plan the surgery, apart from this resection, we need to take out this, and this case, which can be very simply managed with a primary closure, required a flap cover. So these are very important points. Last, when you take out the sample, Do not divide it and send it to two different labs to know which is better. Send it to one histopath lab, which you are confident, which gives you reliable results. You can always take that sample for a second review elsewhere. Why? Because the tumors are heterogeneous. If you divide, one lab will show you something else, low grade, other will show high grade or no tumor. What will you do? Which one will you follow? So send the sample to only the lab where you are confident, which is well accredited for looking for histopathological analysis. So this just to summarize. I'll not waste time because we have a short time. Primarily, what are the types of biopsy? So the gold standard currently is core biopsy, which the other name could be a true cut biopsy or needle biopsy. You need not open it completely. The other type is incisional or open biopsy, where we do open surgery to remove the piece. And third is excision biopsy, where you remove complete tumor during biopsy only. You don't have to go in again. So let us see this case. This is a soft tissue tumor. You can see in the gluteal region, there was a mass. And primarily, these are the instruments that are required. So soft tissue, this is called a true cut needle, and which goes in. I'll just show you the mechanism. So this needle, it has a slot where the tumor tissue is pulled in. And once you hit it, it goes inside the tumor mass and takes the tissue out. So let's look at this video. This is a gluteal region. Patient is prone. You go in with this needle. You fire your gun, and this brings out the tumor tissue, which you need to collect in 10% formalin. So this is what it looks like. You can take 4 to 6 cores. Usually, no suturing is required in these situations. Now, this is for a bone biopsy, how we do a bone biopsy, surgical video. This patient, young lady with a lytic lesion in the proximal femur. We did MRI, which showed a lesion, which is involving up to the neck and the proximal femur. These are the basic instruments. The most important is your Jamshedi needle, J needle, which has a cutting bore, which goes inside the tumor mass. So we take this inside the bone with rotating movements, and then it takes up the core. So I'll show you this video. So 2 syringes to aspirate for local anesthesia. This is the Jamshedi needle, your mallet, saline. When I see that the tumor has some, hemorrhagic cavity, then I add some heparin into it to prevent coagulation. Important is to do the anatomical landmarking. In these situations, we take the help of fluoroscopy guidance. You mark it well. So we do it under local anesthesia. Only children who are non-cooperative, we may have to give sedation or anesthesia, general anesthesia. So this is this Jamshedi needle, and you can see it has a trocar, which is a solid part, and it goes inside this cannula. When we go inside the bone, we should go in with the trocar so that unwanted tissue, the normal muscles and fascia, other things are not captured. We want the main representative tissue to come into the sample. So you go in till the bone, since here the tumor was primarily intraosseous. You hit the bone, and then you try to push it inside, check it under fluoroscopy that you're at the right spot. Sometimes if the bone is hard, you may not be able to penetrate in. You may have to use a mallet to push it inside. So it gives feeling of give way once you are inside the bone. So here the bone was a bit hard, so I use this mallet, and then suddenly you can see that there's a give way. It's inside. We remove the inner trocar. Now we collect this sample. We attach a 10 cc syringe on back of it and aspirate the tissue which comes out. So here we check it that we are in the right spot. So see, with this technique, we do not damage the part of the bone, and we can take out adequate material also. a technical point, when we pull out our trocar, there should be a negative suction so that the tumor cells are not seeded along the track. So when you're pulling it out, you bring it along with the negative suction. So this is like a core which comes out of the tissue. So we repeat this multiple times so that at least 4 to 6 cores are there. And once you have collected, we filter this to see the adequacy. Just 2 minutes, I'll finish. So after filtering it, we can see the tumor tissues are lying there. So ensure that grossly under vision that you have the adequate tissue. Otherwise, you can also send it for frozen if you have any doubt whether or not you have the representative tissue present there. The last one is excision biopsy. Primarily in bone tumors, there is no role of excision biopsy. Excision biopsy means you remove the tumor out. So part of the bone, there are hardly any bones other than expandable bones. You will just remove the tumor to identify the diagnosis. But yes, in soft tissues, when there is a small tumor less than 3 centimeter, you can excise it primarily. The principle is, if you are excising it primarily completely, do it with wide margins, so that even if the final report is some sarcoma, you need not again go and revise it. So this is just a small video that this was around 2.5 centimeter mass, where we remove it, and you can see I am excising over the fascia. This was over the gluteal region. So we remove it with complete wide margins. And this was a case of leiomyosarcoma. So to summarize, biopsy has to be performed after complete workup, and ideally by the team who is going to operate the surgery. And when we submit the sample specimen to the pathologist, we should not try to give them incomplete information or let them identify what it is actually. They are not, detectives. We need to give them complete information. This is the clinical history, 1 year history, 3 months history. It gives them an idea. What do you see on MRI, radiology? Give them complete information, because many tumors under the microscope may look alike. And this proper input, the clinical corroboration, the radiological inputs, along with the specimen analysis, gives us the right diagnosis. Thank you very much.
Vivek, a very nice informative lecture. Just one point of clarification. You have told you have to take 5-6 cores. Is it from the same entry point of the skin, or do you make different entry points?
Okay, sir. So yes, I forgot to mention that. So whenever we go in, if we are inside the bone, through the same entry point, we should not make multiple punctures. We just change the direction. So we can enter the bone or soft tissue through the same hole and change the directions to take out different tissues. Thank you. I think we can take up the questions after the lecture.
Thank you, Dr. Vivek. Next, I would like to request